We've got this really interesting study examining transient variations in Anti-Müllerian Hormone, or AMH, concentrations in a fertility clinic setting.
Yeah, indeed.
Essentially, the research looks at patients' blood test data over months and even years to track changes in AMH levels.
Right, and it seems that even if someone's AMH is low at one test, it might actually rise above diagnostic thresholds in subsequent tests, correct?
Exactly. The study found, for instance, that 42% of patients with an initial low AMH reading below 1.5 pMOLL later had values that crossed above that threshold. It sort of challenges the notion that once AMH falls, it's a one-way decline.
That's pretty significant, especially since AMH is used as a clinical indicator of ovarian reserve. It makes you wonder about other factors behind these fluctuations, right?
Yes, absolutely. The study notes that while AMH generally declines over time, about 1.8 pMOL/L per year on average, the changes can vary by age. For example, in women under 30, these fluctuations are less pronounced over longer intervals.
Sure, right.
However, for older women, the declines tend to be more marked.
So it's like the hormone remains sort of stable in younger patients but becomes more erratic as age increases. But what about the causes for these transient changes? It sounds like there might be a lot at play.
Oh, indeed. The study hints at potential factors such as menstrual cycle variation, vitamin D levels, and even stress responses. Things like FSH signaling that could modulate AMH secretion. There's even a mention that oral contraceptive use might account for about a 17% change on average.
I'm curious though. I'd say while cycle variation might explain a bit, some of these large fluctuations seem to exceed what you'd expect from just that, don't they?
Right, exactly. And that's where the study really challenges us. It shows that although most patients have modest changes, a sizable minority exhibit changes beyond these expected variations. It truly calls for a second test in cases where the patient's profile doesn't match a low ovarian reserve diagnosis.
That's a good clinical point. And was there any discussion on the methodological limitations? I think I recall something about selection bias.
Absolutely. They noted that only a small number of patients had repeat tests, which may not fully represent the general patient population. The retesting was mainly driven by clinical need.
Yeah,
So,
I get that.
While the findings are compelling, we need more rigorous studies to nail down exactly what's causing these transient shifts.
It's like, while the study shows a promising angle, we have to be cautious in applying these observations universally without additional evidence.
Precisely, and it really emphasizes how individualized reproductive physiology is, and that sometimes repeating tests could be crucial in clinical decision-making.
Right on. Overall, this study gives a detailed, data-driven peek into AMH variability. It'll be interesting to see future research building on these findings, especially with larger cohorts.
Yeah, indeed. The interplay of age, lifestyle, and biological factors here is complex and really shows that understanding ovarian reserve is more nuanced than we might think.
Absolutely, couldn't agree more.